Thank you so much, Viveshnu and other Indian toxicology detectives for giving the opportunity and to talk about the Krait envenomation. And I really enjoyed Sujoy's presentation, and it's really very very good. And I just thinking like how God created a species like this and the variety. Definitely, this is like a lot of many of the things that he has mentioned his talk. It is very helpful to explain me the environment and his clinical presentation. So I'm going to. So see, like about the snake bite in general, it is you must consider it is generally it is considered as a occupational hazard, and it is like a common accident reported in tropical and subtropical countries. And usually, what will happen, like the lack of knowledge, improper training regarding the early recognition and reorganization of venomous snake bites, and a rapid intervention in the antivenom therapy. A delay in the rapid intervention whenever a bite occurs, this may lead to gross morbidity and mortality as far as a snake bite is concerned. And usually, that people interact with in the outside house, like the farmers, villagers, laborers, hunters, truckers, house rescue. These are prone for getting snake bite. And again, like migrating populations, again, scientists who are handling with the snake, and also person who taken care of snake bite. These are the few people they are commonly prone for snake bite. About the snake bite, see, when you considering the medical emergency, trauma, then coronary attack, stroke, sepsis, all these will consider as or consider as the medical emergency which require to be attended in a window period. So I would say like the snake bite is also we must consider it is a medical emergency and its management is time limited, and so which must be treated in a window period. If we are out of window period, we may not be able to save the patient. And considering the snake, more than 20 lakh snake bite incidents are reported in India. And of these, more than 46,000 people are die in a year. That means every hour, 5 patients are dying out of snake bites. So it is really a public health issue. We must address it separately. So about the species and all are, I'm not taking because my previous speaker is well explained all this. About the snake is also I'm not taking much time. Just like this is belonging to the Krait is belonging to the Elapidae family. So about that general snakes behavior and all is already mentioned in detail. See, basically these are the nocturnal snakes. So their symptom, once it's bitten, this symptom presentation is mainly it is a neurotoxic, mainly neurotoxics, which is look like a cobra presentation, and also you see like there may not be much local symptoms like necrosis or bleeding. And the symptoms of envenomation include that the drowsiness, neurological or neuromuscular manifestation, and abdominal pain are very common. Definitely, it will cause proximal limb paralysis, ventilatory failure, sometimes coma, which may progress very rapidly. See, like this is also my speaker is mentioned very well. The snake is about 1 meter. Never its length go beyond 90 centimeter. That's all. When again they are usually laying egg in the February. The young will become appear in around the February. They're laying the egg in the between the December and the February, and the young will appear in April. So all in the June, July, this is all the prone area we can get that Krait bite. This is again, Sujoy is mentioned very well the eating habits that the little Krait's house behave, everything. I'm just giving it. So so about the snake venom, Krait venom. See, most of snakes ingest only 10% of the available venom in a single bite, except that Russell viper, which is usually to inject about 75% of the venom, because of it is a long and big, sharp curved flanks. And you see that venom is a cocktail of 20 or more, which include enzymes, proteins, polypeptide, nucleotide, biogenic amine, and many things are there. And this venom is from both, also contain both acetylcholinesterase, phospholipase B, and also glucophosphatase. And coming to the Krait specific, Krait venom is 10 times more lethal than cobra. And sometimes like the victim report too late due to the delayed clinical manifestation. And here it is, the bite mark is very negligible, sometimes unnoticed, mainly because you like that the flank size is, when you taking an injection needle, it is a size, it is less than 24 gauge needle. That is the reason. And this venom containing mainly in Krait containing beta bengarotoxins, and it is something which is act similar to botulinum toxin. And in common Indian Krait venom is also containing both presynaptic beta bengarotoxin and also alpha bengarotoxin, but predominantly they are the beta bengarotoxins. So how does this toxin is going to affect in the neuromuscular junction? So these toxins, particularly the beta bengarotoxins, particularly affect in the presynaptic junction. When you consider the cobra and the toxins are mainly acting in the postsynaptic receptors. Here, in the Krait toxins, which have this chemical containing phospholipase A2, which has A2 activity, which is also called SPANS. SPANS means snake presynaptic phospholipase A2 neurotoxins. Basically, they catalyze the hydrolysis of phosphatidylcholine, which is the major component of the plasma membrane. And this hydrolysis forms lysophosphatidyls and is releasing both saturated and unsaturated fatty acids. So you look at here, the exact mechanism of the toxicity is undefined, but it's all like the hydrolysis of the phospholipids will cause the massive release of synaptic vesicles. And when the synaptic vesicles are released, this will cause initially, it will cause a release of acetylcholine, tremendous acetylcholine release, and later this will disrupt entire the presynaptic membrane and receptors. So here this picture is so like a phospholipid toxin is get into a docking and priming in the vesicle and in the plasma membrane, and later it will go engulfed, and finally it will go hydrolysis, and finally it will totally disrupt that vesicle. This is the way it is acting. And poison nerve terminal show absence of vehicle in subsequently, and which cause a delayed degeneration of the motor nerve. This is something like because of this toxin, which will almost disrupt all the presynaptic acetylcholine carrying vesicles, and this degeneration will take even weeks, sometimes months to regenerate. Sometimes this kind of patient may land up in the ICU for a long time because of this reason. So the recovery takes a long time. And the presynaptic toxins also sometimes may cause myotoxicity, and sometimes it may cause degeneration of skeletal muscle and death from acute renal failure. So there are other snakes also will have that presynaptic toxic. They release that presynaptic toxins like the tiger snake, tapan, or Brazilian rats. It's all the similar snakes which will cause the same kind of toxin effects. So what we understand about that Krait venom. So the toxins, when these toxins is initially come and act in the presynaptic vesicle, a presynaptic area where the toxin initially released acetylcholine at nerve ending and the neuromuscular junction, and then subsequently it will lead to the damage of the apparatus, which will prevent the further release of acetylcholine. Finally, the receptors are damaged and destroyed. So later part, this is the one reason the kite bite may be shown to resistance in the anticholine H6 therapy. That I will explain in the later part of the session a bit of detail. So again, this mechanism, when you translate into the symptom presentation, the initial release of acetylcholine result that autonomic nerve stimulation, which will, and this also augmented by the release of other chemicals like cholecystokinin. So these two chemicals, that acetylcholine and cholecystokinin, will cause the specific presentation features like acute abdominal pain, vomiting, staring look, blurring of vision, blue sweat, salivation, hypertension, pulmonary edema, etc. So now I am coming to the actual clinical presentation of the Krait bite. There are a variety of the symptom presentation in the Krait envenomation. These can be neuro or neuromuscular or general symptoms or many other things. So predominantly, it is a neurotoxin, snake with a neurotoxicity. So the usual presentations include ptosis, that's a drooping of the eyelid, glossopharyngeal palsy, which will cause dysphagia, then cause ophthalmoplegia, it will cause strabismus, it will cause blurring of vision, it may cause dilated pupil. It will cause that proximal limb paralysis. It will cause intercostal and diaphragmatic paralysis. It will cause increased oral secretion. It may cause ataxia. It may cause headache. And even it will cause drowsiness, coma. And sometimes patient may present with facial paralysis or decreased tendon reflex. These two features are particularly seen in malign Krites. Patients will have also general symptoms like these general symptoms will usually manifest with within 1 to 2 hours of the bite. And this, though sometimes like the Krait, it can be go up. The presentation may delayed up to 12 hours following the bite. One of the classical misleading presentation is the abdominal pain. A patient may present in the emergency room with acute abdomen, and the pain is severe to moderate to severe, and may be confined to epigastrium. Sometimes generalized. Sometimes it may be misdiagnosed as acute appendicitis, like that. And this also causes diffuse muscle tenderness sometimes. And blood, it may cause leukocytosis, Usually, like a few small group of people will patients have that cardiotoxin, toxin by the Indian snake venom, but usually it will not cause much cardiac manifestation, except like a transient decrease in the blood pressure, like that. But there are only like very few like severe pulmonary myocarditis and all getting only like a case report. Nothing is reported in a large number. Again, coming to the local symptom, Krait bite, sometimes no local symptom at all. Rarely even a bite mark is seen, and it is very rarely will cause edema. If at all is causing, it is a minimal edema and a minimal pain at the side bite. Because of the reason, we may very easily miss a bite with a Krait. About the fang marks and all, fang marks may be present, sometimes one, sometimes more well-defined punctures. Sometimes you may get a series of small laceration or scratches. Sometimes there may not be any noticeable or obvious markings where the bite is occurred. Sometimes, if at all, say like in the absence of bite mark or the fang mark does not preclude the possibility of bite, particularly if you bitten by a juvenile snake. Similarly, uh, sometimes you may get multiple bites. Sometimes more than a snake is also possible, but the presence of fang mark does not always imply the injection of venom or disposition of the venom into the wound. It's also can occur both ways. It is there. A non-sealed bite mark is not ruling out the bite or the envenomation. Similarly, presence of bite mark, it is not always conclude there is envenomation. So here it is like I am quoting when I am searching about the literature and other data about the Krait bite. I found out one uh, in the one site that is called M3 India, which published this Dr. H. Bavaskar. He shared his lot of experience, and this is something exclusively on the Krait. It seems to be very interesting. Also sharing this also here. According he's is sharing that his experience is like that males are mostly getting bitten by this Krait. Maybe they are going outside, particularly in the northern India and all. And the bite time is mainly it is happening early morning, 12 a.m. to 5 a.m. Most of the bite. Daytime, hardly one bite he has got out of his cases. And most of the bite, majority, 99.29% of the bite happened during the sleep. And most of the bites are happen on the lower extremities. And also here we see patient presentation, which include 26% of the case present to his experience without any history of bite, but features of envenomation. Again, his presentation is look like very interesting. Majority of the symptom presentation, which include abdominal pain, abdominal tenderness, chest pain, and a few other things like the bilateral toxics, difficulty in deglutition, then ophthalmoplegia, etc. And a few percentage of the cases, about 25 to 35, 9 to 35% of the cases having quadriplegia, neck drop, respiratory decision. This is way like he says. This is very interesting. Interestingly he is present there. So now I would like to share a few practical points specifically about the Krait bite. See, because of the negligible or absence of local manifestation, we may, two things will happen. One is like we may totally neglect of the envenomation. And sometimes, like, because of this, people may falsely initiated or falsely attributed to an ant bite or a rat bite or even no bite at all. This causes problems. Or this may be the one reason sometimes the patient presentation to the emergency department delayed much. So the another thing, like the venom sometimes stimulate the autonomic nervous system. This will happen within 20 to 30 minutes of the bite. And these clinical effects are seen within 30 minutes, and sometimes it may delayed up to 18 hours. And sometimes, like, the victims are wake up due to, it's not because of the bite. People will wake up from the bed because of the colicky abdominal pain. Sometimes that vomit, they will vomit once or twice and make chest pain. So even see, like, relatives, even in a doctor sometimes neglect this symptom, and this may be attributable to an acute abdomen. This may go for in the surgical consultation, and this way it will go. Sometimes people may give some anti-colic, antispasmodic, and then discharge it, and then later patient may return to aggravated symptoms. Usually, yes, this may be considered. It is people may consider, if they are not seriously or really thinking about the possibility of the Krait bite, this may attributed to indigestion or acute appendicitis. Even sometimes people may consider it ACS, and sometimes this may cause a minimal T inversion and all. This may be due to the hypoxia, but this patient may end up ending up in the snake bite unit, they end up in the critical care unit, coronary care unit. This may cause further disaster. Other thing, like, see the tissues having, the tissues having high acetylcholine receptors, which will affect it earlier. For example, the tissues or the structures where high acetylcholine receptors, like sphincter pupillae, levator pulmonary superior, the neck muscle, bulbar and limb muscle. These are affected initially. This is the reason why, because these are the area where acetylcholine receptors are abundantly present. And usually the diaphragm and intercostal muscles are affected last in the sequence. So what will happen, because of this pattern, this will cause patient may present you present you with the quadriplegia, aphasia, and dilate. It is say dilated, non-reacting people. Patient is in aphasia, not taking adequate breath, and this will cause. We will misdiagnose it is a brain death, or it may be designated misdiagnosis Guillain-Barré syndrome. But definitely, this kind of situation, this is very specific for Krait bite. Patient is locked. Fully locked. The patient cannot move the limbs, cannot speak, and his pupil is dilated or look like a brain death. This is what is called locked-in syndrome. And the venom is, venom-induced paralysis in the pupillary muscle. This is cause of non-reactive people. This may not be as we may misdiagnose. It is a brain death. But remember, this is a very irreversible sign. It is a very irreversible one, and it is not not an irreversible brain damage. You can very well reverse with antivenom and ventilator therapy. And sometimes, like after recovery, this patient may have the signs or symptom of peripheral neuropathy. And sometimes in the intensive care therapy, patient on ventilator may develop respiratory infection or acute respiratory syndrome. Uh, See, sometimes, like a patient bystander may present with a snake is very classical, venomous. They will bring with a venomous Krait snake, and there will be a bite mark, but there may not be any signs of envenomation. So the time like the Krait victims are bringing the kill snap do not develop any clinical manifestation. There will be, even if there will be a long local fangs mark and without urticaria. This is something what we called a bite without envenomation, or it is also called dry bite. So what will happen, like sometimes, uh, sometimes like even an inexperienced treating doctor may diagnose this is the other side of the story, may diagnose with a Krait bite even if the patient bring a specimen. So this sometimes here it is like there is the upper one is a Krait. This is Dr. Sujoy is very well mentioned that a band starting from the head, from the neck area, it is extending up to till the tail end. This is the features of Krait. But the other one, that wolf snake, is a non-poisonous snake, where see that bands are look like similar, but this will not go to the up to the tail end. It is somewhere in the somewhere here. This marking is so. So this has also we have to remember while in the practical clinical scenario in an emergency room. So, what is next? Next is like once this bite happen, naturally, like that successful resuscitation and successful coming out of the Krait bite or in any snake bite is depending upon a properly instituted first aids. First aid is generally, we can call not specifically for the Krait, can be for the any snake bite. But so someone is bitten by a snake, we may not know like which snake, and so definitely that that first aid management is common to all. So remember like that 80 usually like sorry 70% of all snake bites are non-venomous. Usually the people are afraid and anxiety is the major issue. So we have to we need to ensure that victim appropriately and properly. So what you want like or you should do like the minimum, you need to immobilize the limb in the same way as someone is having a fracture, because the mobility is enhanced, that entry of the circulation and entry of the venom into the circulation and the spreading into the entire body. So you immobilize the limb appropriately, and can be during the transport or in the part of the primary, the first aid. The best position is to keep the patient in the recovery position. This is something like what you can see in the picture. Recovery position, here it is, even if it is patient have a drooling of saliva or vomiters, this all will not aspirate and you can go clearly get into getting outside. Usually like the recovery position, someone is in the theater, someone is received anesthesia, while patient is coming out of anesthesia, and after extubation, the anesthesia people is very fond of this kind of position. There's a word coming from the recovery position from there. So so if you think the patient is unconscious and require so because airway protection, this recovery position is help to protect that airway. Another thing is the use the immobilization you can use any rigid object as a splint. You can use a splint or a wood piece or tree branch, anything, or a rolled newspaper, anything you can use as a splint. And here it is using a splint or an elastocripis bandage. See, like, do not block the blood supply, and also do not apply much pressure, any pressure. So we should, even if you applied this elastocripis bandage, we should be able to introduce one finger through it. So another thing, you as a part of first aid, while transporting the patient, usually what will happen? Someone is involved in a trauma or in a snake bite. Most of the bystanders initially, what they will do, they will give something to eat and something to drink. But this is not a very good practice. Basically, it will reach the medical care facility unless doctor saying keep the patient nil orally, because like particularly the Krait bite and all, this patient may become unresponsive or going into comatose states in any point of time. And if you given something for orally, and if the patient become unresponsive, what will happen? This will get aspirated. So shift the patient to the nearest healthcare facility, whatever is immediately available. So usually that transport using an ambulance is the best one, but whatever is vehicle is available, you can use it in a rural area. Sometimes boat, bicycle, motorcycle, structure, all can be used. This is, like if you are using a motorbike, there must be three person, because always, like, this any point of time this person may lose the proximal muscle wasting, or the person may become. This is not a very safe practice, but if nothing is there, you can use. But definitely, if you want to transport in a bike, there must be three person, and never that bitten person to be allowed to drive the vehicle. That is the most important. So again, like where part of the first aid, what you should do, like you should remove his shoe or the ring, tight cloth, watches, jewelry, etc. Because some point of time and the time moving forward, what will happen if the area become edematous, because these rings or the jewelry or watches and all sometimes cause a tourniquet effect, and this will further it will tourniquet effect, and it will lead to the loss of limb. And if there is blisters are already formed, it may not be in the case of Krait, but in general, it is not disturbed, just keep it there. And if you locate that bite site, if the surface, maybe you can clean with clean cotton or the clean cloth. And the better to keep that bitten part below the heart level. Sometimes the electrocripis bandage is presently it is advisable, and it is used from the distal end of the bite side to the right amount of, using a right amount of pressure, so that it can be easily put and remove the finger underneath. See, most one important thing, like that elastocrip bandage may not be much helpful if you cannot reach the hospital within a 30 minutes, and if you delay more than 4 hours is expected. So the victim, most important, the victim should not be allowed to walk, and if the patient stops breathing, you need to initiate artificial ventilation and definitely this is someone is end up in the respiratory arrest, and mouth to mouth breathing if is okay, if no other device is available, or if it's an ambu bag and all, if someone is able to use, this is quite okay. Here it is. You can see how an elastocripy bandage can be applied. Okay. Another thing, whenever possible, whenever you are referring to a higher center, you to higher center see like that the progress and manifestation of the new symptom and should be updated with the higher center, particularly the progress of swelling, tosses or new symptom. And usually like a person accompany, he should know how to manage respiratory arrest, shock, and also know cardiopulmonary resuscitation. So once reaching the hospital, see, in the emergency room, once you reach what you want to do, like you have to collect all the details, including the patient history, time of bite, patient activity at the time of bite. Then also note the specifically like the initial clinical signs such as bulbar palsy, muscle power, tendon reflex, respiratory rate, oxygen saturation. Sometimes in the bedside you can use an 1 minute counting and look at for the pooling of saliva. Is the look for that broken neck sign. So I'll do in the also if it is there document also. You can do like a blood pressure, ECG changes, all be monitored frequently. You can do like that clotting test, baseline, RFT, LFT, ABG, and other coagulation profile. You can send it. But like when someone is landed up in emergency room, we follow usually like a ABCDE pattern. So you can use the same pattern to assess and manage the patient Krait bite. So as you assess for the airway, if the airway is obstructed, you can manage open it by using an oropharyngeal airway or nasopharyngeal airway. You can use the head tilt technique, other techniques. And if there is a section, pulling of saliva, do oral section, recovery position, all these you can manage. And whenever you think like that airway is compromised, go for intubation. That is the airway management. Endotracheal intubation is the absolute way to protect the patient. And coming to the breathing, assess and manage the breathing. This is usually assess the breathing, how the respiratory rate, how the saturation, how the oxygenation, and if required, initiate mechanical ventilation immediately. And coming to the circulation management, initiate IV line, give the fluid, then attach monitors, draw the blood for the lab and other tests. And the disability D means usually you assess the central nervous system functioning, assess the neurological part, neurological status, and muscle power. Particularly, you see like that signs of bulbar palsy, tendon reflexes, respiratory rate, then broken neck sign, pupillar reactions, all be coming under the neurological assessment. What about GCS? GCS is a bit confusing, and also the E is assess and manage that. You can expose and see the bite mark. This way, you in this priority in this order. Always manage airway first, then manage breathing, then manage circulation, then manage disability, and finally see any mark or any other exposed totally and see anything to be there. And see, like, suppose I told you, like, endotracheal intubation is the absolute way of controlling airway, and this will protect the airway 100%. Sometimes you have difficulty. Suppose someone is not able to intubate, you can also use other airway advanced airway adjuncts like laryngeal mask airway, combi tube or King's airway. All these three equipment devices you can use without any laryngoscope. But absolutely, these three things are you can save time, you can buy time, but this not protect airway 100%, but definitely it will ensure that oxygenation and ventilation adequately. And bedside test, in the bedside, before intubation and all, you can, if you have this equipment, that's a peak flow meter, you should be able to know like whether this patient is deteriorating or improving, as because this will measure that this will, like, okay, you blow into the equipment, and this will measure that peak inspiratory flow rate, and this will predict that neuroparalytic symptoms. So if that this is not a costly one, it's costing about less than 1,000 rupees, and it is if this not available, you can very well can do a other bedside test for respiratory adequacy, like a single breath test, breath holding test, or ability to complete one sentence session. About the GCS one, but like people are using GCS randomly here and there, but at least like for that for the Krait bite is concerned, no role for GCS assessment, because it cannot be used to assess the level of consciousness, because patient is paralyzed by a neurotoxic venom. And someone is in the emergency, you do like arterial blood gas and do urine examination more frequently to know that progression or deterioration of the systemic toxicity. So like the antidotes for Krait bite. This is the best antidote is the prevention. Sometimes, like you can use the pharmacological or physiological antidote like neostigmine and atropine. Immunological one is anti-venom. Mechanical is a ventilator. So see, like once you identified and decided to give, if it is a Krait bite and it is a neuroparalytic bite, you can move to the administration. You must give 100 ml, that is a 10 vial of anti-snake venom. Should be added. This can be added into 200 cc of the normal saline, and should be given in a time period of 30 to 50 minutes, or 30 to 1 hour, half an hour to 1 hour. And here you see, like we should sit along with the victim and should monitor closely the response, and also for that acute allergic reaction due to the ASV. So what you need before starting in the ASV, you need a crash cart along that. The crash cart which make your resus is perfect, or resus is adequate, and which include all the emergency drugs, oxygen, everything will be there. And also, it is better to practice before giving ASV load adrenaline. Keep the loaded adrenaline. Two doses of loaded syringes of loaded adrenaline to be kept ready. So now everyone will be concerned about the ASV. Very often, the non-availability of the ASV. Petrol, sometimes ASV is available. People are a bit of reluctant to give. These all issues are there. So few concerns about ASV, and I am enumerating here. So few some of the practical points, like suppose someone is required an ASV, should be given within 30 minutes after the, and when it should be repeat. If it is repeat within the 30 minutes after the initial dose, ASV is not showing no improvement in neurological manifestation, one can repeat the second dose. But remember that the maximum dose is 20 vial for the neurotoxic bite. Another point, like ASV is neutralizes only the circulating venom. It has no action once the venom is attached to the receptor site. So that you have to understand. See, you here is like a Krait bite. See what is happening. There is a destruction of the receptors. So the neurological manifestation may persist for weeks till there is this will continue till the regeneration of receptors. At this stage, administration of ASV, after once everything is fixed or that degeneration process is started, the ASV doesn't have much role in the snake bite. Another thing, there is no contraindication to give ASV to a pregnant lady or to a lag mother. And also, if a child brought to emergency room with Krait bite, the dose of ASV is the same as adult, because that irrespective of the children or adult, snake will inject the equal amount of venom. So again, 10 points, 10 general rules as far as ASV is concerned. The ASV is indicated, for example, symptom and signs of envenomation with or without evidence or laboratory test. So administer, what you want to know, administer full dose without any delay. If you decided and if it is indicated, go ahead with the full dose. And do not wait to get any test reports. So this will again delay and things become more complicated. The history of the bite and known or unknown, if there is a spontaneous abnormal bleeding beyond 20 minutes from the time of bite, start ASV. It is not wait for you need not wait. This as far as the other bite, not very relevant for Krait bite, but other bite. So no absolute contraindications to ASV in any scenario. Even patient with a history of allergy, if it is indicated, you can give ASV. So do not routinely administer ASV to any patient claiming to be bitten by a snake. So someone is still someone say it is bitten by a snake. That is not an indication to give ASV. Again, do not delay or withhold ASV on the ground of anaphylactic reaction to a deserving dose. Do not do not give incomplete dose. Whatever the dose, give the complete dose. Local swelling accompanied by a bite mark from an apparently venomous snake is not an indication to administer ASV. This is another contradictory thing. So again, like the swelling number of hours old is also not an indication is for giving ASV. And lastly, the rapid development of swelling, which indicate bite with envenoming requiring it. That is something very, all these are not an indication. But here, someone is present with a local swelling and bite mark. If it is present hours later, this may not be an indication. But someone is present to you with rapid development of swelling, which is really indicated for ASV administration. So people are so much worried about ASV reaction. That is the reason why the people is always sometimes reluctant, particularly in a rural area or in a small hospital center. People are a bit of reluctant to give ASV reaction. I think it is better to add a few points about ASV reaction. Generally 20 to 60% treated with the ASV develop either early or late mild reaction. But ASV is test dose. No ASV test dose must be administered. So test dose is not required to give ASV. Even a skin conjunctival hypersensitivity to testing dose not reliably predict the early or late antivenom reactions. So it is not recommended. So what are the reactions you can get in ASV following ASV administration? It can be the three type of reaction you will get. One is early reaction, that is a really anaphylactic reaction. That is the most dangerous among the group. Second one is a pyrogenic reaction. And third one is a late serum sickness kind of reaction. So the early reaction usually present within 10 minutes to 180 minutes of the start of the therapy. This usually characterized by itching, urticaria, dry cough, nausea, vomiting, abdominal colic, diarrhea, tachycardia, fever. This is really present. So a few patients may really end up into a life-threatening Anaphylactic features this include hypotension, bronchospasm, airway obstruction, angioedema, etc. A pyrogenic reaction usually occur 1 to 2 hours after the treatment. This usually present with chill, rigor, fever, and hypotension. They usually cause like that contamination of the ASV during the manufacturing process. So any new sign or symptom after starting the ASV in the drip should be considered or should be suspected as an ASV reaction. So coming about that late reaction, she usually develop. It usually develop 1 to 12. That is 12 days after the treatment. This may present with fever, nausea, vomiting, itching, etc. It also will have recurrent urticaria, arthralgia, myalgia, lymphadenopathy. This may lead to immune complex nephritis and encephalopathy. So how do you manage this? Usually, you can, if you want, you can give a prophylactic epinephrine before using epinephrine before starting ASV. This an adrenaline 0.5 milligram can give subcutaneously. And be cautious or be about patients with cardiovascular problems and hypertension. So using the pre-medications like histamine, H1 receptors and H2 receptors, corticosteroid, etc., do not affect the incidence or severity of the early antivenom reaction. This is the one study is called. So, if the early reaction, treatment of early reaction, what the first attempt immediately stop the ASV administration temporarily, initiate oxygen, give an IV fluid, then give an epinephrine injection. Epinephrine is the antidote for the ASV reaction. It's given intramuscularly, half ml. That's a 0.5 milligram. So can add the chlorpheniramine or the hydrocortisone, but it's all like unlikely to be much useful once the reaction is happened. So another thing, like once that reaction is treated, so you have to restart that ASV slowly in 10 to 15 minutes, then keeping the patient close observation, and then also resume the normal rate. So someone with so who are the really prone people or high risk people for ASV reaction? People with the history of hypersensitivity, people is having a previous exposure to animal serum like equine ASV, tetanus immunoglobulin, anti-rabies immunoglobulin, etc. People with a severe atopic. This kind of people are high risk people. And this kind of people, when we are taking for or we are planning for giving ASV, you can give a pre-medication of hydrocortisone and chlorpheniramine malate. Suppose that patient with a late reaction, that treatment include chlorpheniramine malate, or it can give like the prednisolone. You can give in divided dose. Desensitization procedures. You suppose like a patient is in severe reaction. If you want to do a desensitization procedure, how will you do that? It's like only this will do only in severe cases of anaphylaxis to ASV reaction. Usually, like or like the patient with generalized nasal cough injection of a few ml of ASV. What we'll do, like we'll change the one thing we can do, the change the ASV. We can add the pre-medication. That pre-medication include hydrocortisone, adrenaline, and promethazine. And then like we can have like a dilution and injection desensitization protocol also. This is simply like to do a desensitization after the severe reaction. When we are starting this again, you can follow this. What you can do, like you can take 1 ml of ASV that you dilute into 9 ml of saline, that you can mark as solution A. From the solution A, again you take another 1 ml and then add 9 ml. So that will get another 10 ml. That you can call it the solution B. that the dilution is 1 in 10. Similarly, you can take another 1 ml from the B, then add 9 ml, make it 10 ml. That is a solution C. That's like a 1 in 10, 1 in 100 dilution. Take 1 ml from solution C, then dilute with 9 ml, then it will become this label as solution D. This is the dilution 1 in 1000. And you take 1 ml from this solution D and then dilute with 9 ml, then make it 10 ml, then you will label it solution D. This is the dilution 1 in 10. So once these 5 solutions are ready, what you will do, like initially you inject 0.1 ml of solution E intravenously, then you watch for any anaphylaxis. If no reaction, inject another 0.1 ml solution again from solution C intravenously. Again, you watch for anaphylaxis for 15 minutes. If no reaction, what you will do, you inject that entire the E solution. That's the first solution. That is a last solution with a 1 in 10,000 dilution. Once this 10 ml is in, what you will then again you watch for 15 minutes. If there is no reaction, what you will do? You give after the E injection is continue and some process follow is in this sequence. Once the E is over, you do inject all the D solution, then you inject all the C solution, then you inject all the B solution, then inject all the A solution. And if every time you look at there is any reaction is happening, if nothing is there, give the full dose. So about a few words about atropine and neostigmine. See, like the atropine is neostigmine is anticholinesterase. This is exactly like this neostigmine will block the postsynaptic receptors competitively, and it will help to competitively eliminate whatever the venom attached into the postsynaptic receptors. But the Krait, like most of the pathophysiology will happen in presynaptically. But there are sometimes some of the Krait toxins will also having that postsynaptic mechanism that may be beneficial with this drug. So what you can atropine is just to counter the muscarinic effect of the what we want the nicotinic effect, but the muscarinic effect of the neostigmine, because the neostigmine will, if you are not adding atropine, neostigmine will cause bronchoria, excess secretion, bradycardia, hypertension, etc. So atropine will only add to prevent this effect. So what we have to do, like we can give neostigmine of 1.5 milligram and add 6.6 milligram atropine, and this dose can be repeated every 30 minutes up to 5 doses. So what will happen, like children, you can use this per kg dose, and sometimes you can available the fixed dose combination of neostigmine glycopyrrolate IV use, that also you can use. It's available. So what will happen is, like, you can taper that dose with a 1 hour, 2 hours, 6 hour, 12 hour way, and the majority of the patient will improve within 5 doses. So this I am talking about generally the neuroparalytic cases. So observe the patient closely and observe an observation of 1 hour to determine if the neostigmine is effective. After 30 minutes, the improvement is not visible, which is usually the improvement is usually like 30 minutes. You can see the improvement in the tosses. Usually you look at how the tosses, how improved the tosses. Usually, if it is a neurotoxic venom, will respond within 30 minutes. But see. You have to stop the atropine neostigmine administration in the 3 following scenario. One is like if the patient is completely recovered from the neuroparalysis, or if that side effects or from the atropine neostimin, that the fasciculation or bronchoria is appear, or there is no improvement within after the 3 doses. So if there is no if the patient is improving with the atropine, what does it mean? It means like improvement means this likely a bite from a cobra bite. Usually the cobra bite is respond to the atropine neostimin. And sometimes few snakes like a Nilagiri Russell viper is also respond this atropine neostimin therapy. But see, like if there is no improvement, if there is no improvement after 3 doses of atropine neostimin, what you have to conclude? This bite is probably due to a Krait. And because like the Krait is affecting presynaptic fibers, like in the presynaptic fibers, that neurotransmitter is predominantly calcium. The calcium is the predominantly acting in the presynaptic fibers. So what you can do, if this not responding to atropine neostimin, definitely you can have a trial with the calcium gluconate, 10 ml calcium gluconate slowly for 5 to 10 minutes. You can repeat in every 6 hours. And this will continue till it's recover for the last 5 to 7 days. So final part of this session is for few advanced management. So who are required mechanical ventilation? Mechanical ventilation is a patient with pooling of saliva, or is unable to lift their head from the pillow, or there is a reduction in the oxygen saturation or dip in the oxygen saturation, respiratory failure, abdominal thoracic respiration, then clinical signs of hypoxia, clinical signs of carbon dioxide. All these patients required intubation and mechanical ventilation. Definitely, the other like lab tests like ABG is also substantiated. So, like as I mentioned, that a ventilator is the mechanical antidote for the Krait venom. Most invariably, many of the patients will be survive with the mechanical ventilator. Sometimes in some patients present with uncontrolled hypertension, this is usually attributed to the blocked presynaptic receptors and unlocked postsynaptic receptors, which is cause release an epinephrine into the circulation. At the time of this, we can maybe land up with acute myocardial infarction and pulmonary edema. Such kind of patient may require vasoactive therapy like nitroglycerin drip or sometimes bypass ventilation. And in severe cases, severe hypertension and tachycardia may end up into the pulmonary edema, which will respond to the nitroglycerin drip and BiPAP therapy or non-invasive ventilation. So finally, to conclude this session, see, like any kind of snake venom, it can be usually the bites 70% are it can be either an overt bite or an occult bite. In the occult bite, usually there won't be any history of bite. Is invariably this likely to be a Krait bite, and where it is present with neuroparalytic symptom and abdominal pain, vomiting, etc. Okay, so where like ASV is the treatment early initial the number one choice of treatment. You can have an atropine neostimin, but definitely the ventilation is the next one. And sometimes like in the overt bite, that is that 70% are non-venomous, 30% are venomous. Out of this, if it is symptomatic, the symptomatic patients with a neuroparalytic symptom, this bite likely either a cobra or a Krait. And coming to this, that most of these cobra Krait bites will present with 5 Ds and 2P for the easy remembrance. 2P is the ptosis and paralysis. 4 Ds are the diplopia, dysarthria, dysphonia, dyspnea and dysphagia, where SV and ventilation is indicated. So all these you can also do in a simplest format. Someone with a history of snake bite, look at whether the local edema is present or absent. If local edema is absent, ask the leading question: where's the bite from the bed, floor bed? It is happening in the floor bed. Does the patient is having an abdominal pain? Does the patient is having a neuroparalysis? No doubt, this is a Krait bite, where your management strategy is ASV, ventilator, and neostillator. So, thank you so much for your patient listening.